Why would a hospital not allow a urologist to perform cystoscopies in the office? And can you bill an E&M service in an ambulatory surgery center? These are a couple of questions we're going to answer and explore in this video. This is a question that came from an anonymous member in a Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit for free. And for those of you who do not know me, my name is John Lin. I'm a urologist in Gilbert, Arizona, also your humble host of this Thriving Urology Practice Facebook group. Let's get into it. This is a question posted by someone 4 days ago, and it goes something like this. Need some advice from the group. After 15 years in a hospital-based practice in a larger city, I signed a letter of intent with a new system that focuses on smaller hospitals in rural areas. In discussing the startup of the clinic, the hospital organization says none of their existing urologists perform in-office cystoscopies because of reimbursement issues. They want me to perform cystoscopies in an ambulatory surgery center with the patient under local anesthetic. There'll be no monitor anesthetic care or general anesthesia typically. It'll be done in a procedure room just outside of the sterile OR area. I'll be reimbursed on a work RVU model. I cannot participate in the ASC ownership as it is solely owned by the organization, hospital. The ambulatory surgery center is across the parking lot from the office in the hospital-owned medical office building. Is this a way for the hospital organization to lower work RVUs and therefore my reimbursement? And can I still charge an E&M with a modifier 25 in the ASC if I find something and I have to further discuss operative management with a, for instance, TURP, UroLift, TURBT, etc.? Office cystoscopy is so important in how we manage numerous urologic diseases. I just don't understand why the hospital is having me do this in an ambulatory surgery center. I'm wondering if this is now commonplace elsewhere. Thanks for any advice. All right. The questions may seem simple, but there's so many concepts that you need to understand before you can successfully answer these questions. So let's answer the first question regarding whether or not the hospital is trying to cut your reimbursement, work RVU wise. So it is important to understand what a work RVU is, or what is a total RVU. Total RVU includes work RVUs plus practice expense plus malpractice expense. And I'm talking about total RVUs, but not how much you actually get paid, because to find out how much you actually get paid, you have to take into account something called GPCI, Geographical Practice Cost Index, and your conversion factor. We're not going to deal with that today because you are being paid by work RVUs. So work RVUs is just a component of total RVUs. So let's take a look at, let's say, if you were to do cystoscopy in the surgery center and also versus surgery that you'll do in the office. So this information comes from AUA Coding Today. And you can subscribe to this. I think you could get a 3-month free membership trial or something like that. Go to auacodingtoday.com. I have no financial interest. But cystoscopy gives you 52000, okay? And if you scroll down all the way here, looking at the fee schedule, you will see that work RVUs is 1.53. Now, this does not vary depending on where you perform the procedure. For instance, if you were in a private practice urology office, you would get the non-facility practice expense of 5.49. But if you were to do this in the surgery center or the hospital, facility expense facility practice expense will be 0.64. Okay. This amount here is to take into account the cost, all the stuff that you would need in addition to you, the professional component, you physically doing the procedure. For instance, you'll be reimbursed for your supplies, the tubing, the facility that you have, the office space, the tube, the water, irrigation, the sterilization. Because you're doing this in your office that is not owned by the hospital, you will be paid this additional practice expense. However, if you were a hospital employee, you would be classified as a facility. And the facility means the facility payment practice expense will be lower. But there's a way for the hospital to make up that difference, and that is in terms of facility fees, which is much higher than what you would be reimbursed in a non-facility setting. So it is important to understand what total RVUs are, what is a work RVU, and what is a practice expense RVU and malpractice expense RVU. You are being reimbursed, I bet, I'm just guessing, a base salary plus a production bonus. So if you hit a certain work RVU threshold, you would be bonused, whether that is whatever the total work RVUs above the threshold, you'll be paid by multiplying the excess work RVU by some other conversion factor and all that good stuff. I have heard employed urologists where their excess work RVU, say for instance, you reach a threshold, any additional work RVUs that you achieve will be reimbursed or paid at a lower conversion factor. It just totally does not make sense to me. You work harder and yet your conversion factor will be lower. So there's no incentive for you to work hard. It just doesn't make sense. Your work is being devalued as you work more. Anyway, I'm just getting off the topic here. So your work RVU is how you are being paid. And you saw here that your work RVUs will be the same whether you perform the cystoscopy in the surgery center or in your hospital-owned medical office building. And I'm making an assumption here that you are, the original question didn't specifically state that you are going to be working in a hospital-owned medical office building. I'm making that assumption based on, I'm reading between lines here. So the hospital asking you to do it in the surgery center because of reimbursement issues, I don't quite understand why there will be a reimbursement issue. Because the office building that is owned by the hospital in which you'll be operating, in which you'll be seeing patients, that office, whenever the patient sees you in that office, the patient will incur not just a fee for your professional services, but also a facility fee, And that's where a lot of hospitals, that's why so many hospitals are purchasing physician practices, because not only do they benefit from charging the professional fee, they also get to charge a facility fee. And that facility fee will be present whether you perform the cystoscopy in your office or in the surgery center that is also owned by the hospital. So I don't understand why there's a reimbursement issue unless the hospital is so inefficient that they can't figure out how to get prior authorizations to perform cystoscopies in the office versus the surgery center. I would think that it probably is more headache to get an auth to do a procedure in the ASC because the costs are higher. The cost to do anything in the surgery center and the hospital is going to be higher versus doing it in the office, in the clinic. So the only reimbursement issue is that it may be low, it may cost the patients less, it may cost the insurance companies less, and the hospital the organization stands to make more if you do the procedure in the ASC versus doing it in the office. So I don't quite understand why it would be a reimbursement issue, other than they would make less if you did it in the office versus doing it in the surgery center or the operating room. So Generally, it should not be an issue if the authorizations are obtained irrespective of place of service, but I can see that it will be a reimbursement issue if you do it in the office because it is paid less than if you did it in the ASC. You personally are getting the same work RVUs whether you do it in the office or in the ASC. So you're not getting a discount, but the hospital system may get paid less when you perform the procedure in the office versus if you were to do it in the ASC. Last year, when I was presenting at the Urology Advanced Coding and Reimbursement Seminar, this question was actually raised, and I said, well, why do you have to do a cysto in the ASC? It doesn't quite make sense. Someone actually said that if the payer is Medicaid for a private practice, this is not a hospital-owned urologist practice. This is a private practice, okay? This attendee said, if the payer is Medicaid, it is literally not possible financially to do a cystoscopy, to do a cystoscopy in the office, in this private practice office, not hospital-owned. It is financially not feasible to do it in the office because of the extremely low reimbursement payment by Medicaid in his geographic area. So in his case, he said he has to take it to the ASC, otherwise he would lose money by doing the cystoscopy in his office. So that is one instance where the place of service changes because of extremely poor reimbursement. A couple of thoughts. Number one, this private practice urologist should consider negotiating with their state's Medicaid. Yes, you can negotiate with Medicaid and get more favorable payment so that you're not losing money and you can't provide the service for the patient because the payer, the fee schedule is so low. So number one, you can negotiate with Medicaid to get a better rate. So forgot the second point I was going to make with this Medicaid situation, but you don't have to do it in the ASC for this Medicaid patient if you can negotiate a better rate for your payment of a cystoscopy to be done in your office. So think about that. All right, let's see. Here's something to consider if you are being asked to do cystoscopies in the ASC only. Even though the ASC is literally across the street from where your medical office building is, and again, I'm assuming that your MOB is owned by the hospital. Even if it's simply across the parking lot, you just walk across the parking lot to go to the hospital to do the procedure. Keep in mind of all the headaches, the hurdles, the consent form, the pre-op area where you have to see the patient, do all the additional paperwork, making sure that your H&P is up to date and all that stuff. Efficiency is where you will lose out, because you have heard me say this before, the OR is nothing but an expensive hobby. And I further state this, anything in a hospital is nothing but an expensive hobby when it comes to efficiency and productivity. The time that you would spend or waste by dealing with the regulations, the hurdles, the headaches in the surgery center means less time that you get to spend in the clinic or free time that you have. Less time in the clinic means you are less productive, because for the same amount of time that you spend in an ASC, you can be much more productive in the office than anything that you can do in the ASC, okay? In addition, the patient's out-of-pocket costs will be higher in a facility, whether or not it's in the hospital or at the ASC. But because of the headaches, the patient also loses out on the time and the hassle involved with the ASC. This leads to delay in care. And also the patient will incur higher out-of-pocket costs due to the higher reimbursement for anything done in the hospital and the ASC. So those are some of the things that you have to think about. You have to understand that work RVU wise, it's going to be the same no matter where you do it, but you got to think about the impact on your efficiency, on your productivity, the time that you spend. You may be young, you may not care about time, but you'll soon discover that time is the only asset that you cannot buy with money. And time is not a renewable resource for you. So think about that. Also, you got to think about the cost to the patient, the greater out-of-pocket cost to the patient. And this facility fee thing has been on the radar for many, many years. So this is an article by Consumer Reports in 2019, the surprise hospital fee you may get just for seeing a doctor. And they're specifically talking about facility fees that don't exist in a private urology practice versus a hospital-owned practice. Gave an example here of a 61-year-old who went to Cedars-Sinai Medical Center and received a bill for over $3,000, $1,700 for the exam, X-ray, and injection that he received, and an additional $1,375 for hospital operating room services, even though he was never in the hospital, never in the operating room. So that is just something that is on the radar for many, many people. And there's some legislation, and I think 6 or 7 states now limit the ability and amount that the hospitals can charge relative to facility fees. And this is an article from ALM Benefits Pro outlining how a 3-year-old had speech evaluation in 2021 via telemedicine and received an initial bill for $676, and that the mothers thought it was expensive, but then she got slapped with an $850 charge for a facility fee, even though she and her child never stepped foot in the hospital. And this was done via telemedicine. Never utilized the hospital's physical plant, yet she was charged a facility fee because the physician was owned by the hospital and provided the service in a hospital-based facility setting. Yeah, it's kind of screwed up. So keep that in mind. Understand that your work RVU is different than what the hospital is being paid, and understand what your patients will go through, and understand also from the hospital's perspective why they want you to do it. And think in terms of how it may impact your efficiency by having to step foot outside of the office. I can tell you, as a private practice urologist, I rarely take my patients just to perform cystoscopy. As a matter of fact, 0 times this year, no one went to the operating room just for a cystoscopy, because I can do the cystoscopy here in the office. It is much more efficient to do cystoscopies here in the office than the surgery center. So someone in the comments, in the question that you posed, said that the only reason why the cystoscopy is being done in a surgery center is because the physician owns the surgery center, which is something to take into account. Why? What is the medical necessity of taking this patient to the surgery center just to perform a cystoscopy that could have been performed in the office? And if this type of practice was being scrutinized by the Office of Inspector General, Medicare, whomever it may be, that's going to be a pretty hefty fine when there's no medical necessity to do so. Now, some patients who are extremely anxious or maybe have some anatomical abnormalities, I can see the reason to do a cystoscopy or maybe a prostate biopsy or stent removal in the surgery center. But for the great majority of patients, I don't think you need to do that. Need to take the patient to the surgery center just to perform some of these very routine procedures that may be performed in the office. So think about that as you go through this journey, as you go through this negotiation with the hospital. And it doesn't matter if it's a rural hospital or a metropolitan hospital, the issues are the same. All right, the second question you asked was if you could bill an E&M visit using a modifier 25 in the ambulatory surgery center. And your example is actually perfect. you perform a cystoscopy in a patient who did not undergo monitor anesthetic care or general anesthesia, but just had a local anesthetic, and I'll have you consider this. I have not used a local anesthetic routinely on flexible cystoscopies for over a decade. So always challenge dogma. All right, back to this. Yes, you can charge an E&M service when that service is being performed in the ambulatory surgery center, when the patient has not received IV sedation, monitor anesthetic care, general anesthesia. And the reason I say that is because the patient can give you consent, can mentally engage and be involved in this shared decision-making after you performed a cystoscopy and found something significant. The concept of global package needs to be understood whenever you're talking about modifier 25. So understanding that when you perform cystoscopies, what is included in that generous fee that you're paid for that cystoscopy? It involves you telling, in your situation done in the facility setting, it involves you telling the patient, making sure the patient can undergo the procedure, you doing the procedure, and informing the patient of what you found, and making sure the patient understands recovery and all that good stuff. What is not included in the global package is, what do the findings mean? What are the implications? What are the management options of the incidental finding? Okay. Discussing the treatment options and ultimately deciding via shared decision-making and via your recommendations, ultimately deciding on a treatment, and the discussion regarding the perioperative course or the risks and benefits of medication, etc. And then you getting the patient ready for that surgery, discussing the preoperative testing, the laboratory testing, maybe getting clearances, stopping anticoagulation, etc. All that I just discussed is not included in the global package of a cystoscopy. So whenever you provide that significant and, very importantly, separately identifiable service, both in content and also in documentation, whenever you provide that extra service, you can bill a modifier 25 event, an E&M service using a modifier 25 in an ambulatory surgery center. Now, what I'm about to say doesn't matter to you, but to the coder and biller, it would make a difference because the claim will be submitted using place of service 24, which is ambulatory surgery center, versus in the office, which I believe is place of service 11. So that doesn't matter to you as a urologist, but it matters to the coder and biller as to the place of service when you submit a claim, an E&M service that is provided in an ambulatory surgery center. So say you perform a cystoscopy, you find a bladder tumor, you talk to the patient about the findings, the implications, the treatment options, ultimately decide to have the patient undergo TURBT with immediate postoperative intravesical chemotherapy. You talk about the perioperative course, you schedule the patient for surgery. You need to document, not only do you actually need to provide the service, but you need to write that down in a separate, ideally in a separate type of an area, so it is easy for any auditor, coder, and biller to look at your documentation and say, yep, number one, there's medical necessity. Number two, there is a significant and separately identifiable service, both in nature and also in documentation, that was actually provided. So yes, you do qualify for a 99214 modifier 25, for instance, with 52000, and you'll be paid for the work RVUs for the 52000. Okay, I hope that makes sense. So yes, you can use a modifier 25, and you can bill an E&M service if you were to perform that service in the ambulatory surgery center when the patient did not undergo sedation, and when the patient can engage with you in a coherent and actually medical legally defensible manner for you, because the patient has to be mentally competent in this shared decision making. So I hope that makes sense to you. Okay. All right. What else? In addition, whenever you provide any sort of a service, I don't care if it's a cystoscopy, if you're seeing patients in this hospital-owned clinic, or if you do an E&M service in a surgery center, you want to make sure that appropriate credit is actually being given to you, because the hospitals are horrible at keeping track of your productivity. Make sure that you are independently keeping track of your production, what you're doing. Make sure the appropriate credit is actually being given. In addition, make sure your E&M visits are not being deliberately downcoded. Yes, automatically and deliberately downcoded. Even though the claim is going out under your MPI, hospitals and hospital systems have been known to automatically downcode, like say your 99214s or 204s to a lower level. So it is up to you to keep track of what's going on in your production. Never, ever trust the hospital and their billing staff, because they lie. And they're extremely inefficient in doing anything, including keeping track of your productivity. All right, let me see if there are any comments in this live stream. All right, as usual, if you have any suggestions, agreements, disagreements, comments, please leave them below. As always, thank you so much for the privilege of your time. Please take care of yourself and each other. Merry Christmas as I record this on December 24th, and have a great new year. Bye-bye.